100 stick success, first stick success. Consecutively, 100 patients, 100 IVs. Has anyone able to achieve that? That's a lot. That's a lot of people, that's a lot of blood. I want to get a feel for the room to see what everyone knows and what everyone doesn't. So shout it out if you know the answer. We don't have to be quiet. Okay. It's so painful. What size is this catheter? All right, we've got some peds people. What's 14. Who got 14? Okay. Good color recognition. Okay. How long do we scrub the skin? Okay. How long do we wait for it to dry? Until it dries. Check. Can you guys hear me better? Okay, there we go. Until it's dry, bacteria is killed by dehydration. What about the next one? How long do we scrub the hub? Jeez. 15, 20 seconds, good. What about after the alcohol caps, chlorhexidine caps? Oh, do we have to? What does rubbing alcohol not kill? C. diff, spores, protozoa, certain other organisms. How often do we replace the IV? Ooh. 3 days, 48 hours. Who else? 3 days. Anybody know the Infusion Nurses Society? It's the body of work that gives us the guidelines on everything infusion and vascular access. Until clinically indicated, you keep that bad boy in there. Oh yeah, oh yeah. What is pulsatile flush? There you go. Boom, 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 boom. Yes, not laminar flow. Definition of a midline. Stops at the axilla. You can't say anything because you know too much. All right, what is the proper sequence to clamping? Clamp as you flush, stop and clamp. Either way, you clamp before you disconnect. It's the key part because a lot of you'll see it in the demo. If you haven't seen it already at the exhibit, it will reflux a lot of blood and you're sitting it in there causing it to clot. It'll fail. Is it even necessary? Of course it is, every single time.
Excuse me, everyone. Sex! Now that I have your attention.
You don't have our attention.
Money!
I'm listening.
You had me at sex.
Pervert.
Okay. Why did I show you that? For things to change, we need to address the elephant in the room. What I like to say is we need to address the pervert in the room. Okay? What do I mean by that? We should use the ultrasound as standard, not the exception. I know there's a lot of hurdles, and we're going to go over that as well. What do I mean by pervert? Do I mean that you're a sexual deviant? Of course not. Do I say that I'm a sexual deviant? I hope not. What is this? We know the second word. What's the first word? Yes. No, that was good. Not a lot of people know this. Immediate auscultation in the 1800s was revolutionary. Do you understand? We can observe the inside of your body without having to cut you open like we used to. Now we can get closer to a proper diagnosis and treatment plan. It was amazing. It was the new thing in the 1800s. It was a game changer until things got a little weird, okay? This wasn't drawn in 2000. This was drawn back in the 1800s because of the stigma behind this practice. People were non-compliant. They didn't want to see the doctors anymore. It was we became vectors for lice. We became vectors for bed bugs, for infections. Aren't you glad we don't have to do this anymore? Right? I mean, I'm happy I don't have to touch the patient at all, but, well, I'll take this one. René Laennec invented the stethoscope. Thank you, good sir. Now we have more accurate. It is better. It is safer, and it is evolving constantly, and it is now standard. How awkward would it be if you walked into my patient's room and you saw me and we lock eyes and then I walk away very quietly without saying a word? It's so standard to use the ultrasound or to use the stethoscope that is now awkward to not use it. It has become standard. Now I'm sure there was resistance, like imagine this back then before they even knew bacteria was existent. How can you hear better when I'm further away from the body? That doesn't make any sense. We have to be closer. If a speaker's playing music, doesn't it make sense that I can hear better if I get closer to the speaker? Right? So I'm sure there was a lot of resistance as well back then until we've adopted this practice. Okay, why am I talking about stethoscopes? We started our pervy journey with the immediate auscultation to the stethoscope. We've adopted and advanced our practice. I'm hoping that over time, we can advance our IV practice as well. We've been doing this since the 1500s, and we still insist. How many of you have heard people say, I don't need training on the ultrasound. I don't care. This is my ultrasound. I was that guy until I saw Lena taking those hits, those 100% sticks, and I was like, I kind of suck at this right now. Let me see if I can get better at inserting. So, am I saying you're sexual deviant? Of course not. However, the negative connotation are the same, and I think we're going to progress, and people who do not adopt this will be left behind. How many times have we done this to our patients? It's funny and it's not funny. But this happens all the time. Our current measure of success is get the IV in no matter what. Why? Because when they're in the ER, if we cannot get you those meds, you are going to die within a day, 2 days, 3 days, 2 hours, 2 minutes. So we will poke you as many times as it takes to get that IV in because we need to save your life. However, with new technology, we don't have to traumatize. I don't have to traumatize them 12 to 20 times. That number was the highest that I've heard reported from a patient. What measure of success should we be? First stick success. How many times have a surgeon told you, hey, that appendectomy, we're gonna have to try it again? How happy will you feel about that, right? Luckily, the patient's not awake for that one, right? But they're awake for our IV insertions. This is one of the hardest things for the patients. They're already afraid of needles at baseline. It is not evolutionarily normal for us to want to poke things through our skin. And we're telling them, hey, we're gonna have to poke you multiple times. First stick until end of treatment. This is my new goal. After Hartford Hospital had an 89% success rate, forearm PIV, 89% of it lasts until end of treatment. Some of them ended for 13 days until they were discharged completely. Thank you, Lena. So we need to raise the bar for our patients' sake. Why make our patients go through more trauma when they can't afford? We can't afford it. How much are they? This is not rhetorical. I want to know. 10,000. 34,000. It's pretty expensive. It's more than my car for that little device. That is true, but now it's not. The probe that you saw out there during the exhibit is about $2,700, not including the phone or the iPad. It's affordable now. The price has been lowered. It's attainable. It's reachable. What's the cost for the patient? Can you feel that? I can't because I've never had that happen before. I can try to empathize, but I don't know what that feels like. This is a patient who was told by her staff, it's normal to burn. It's normal for it to burn. There's no swelling right now. It's not red. She was complaining of a little pain while I was infusing, so she said, fine, I trust them. And then another day goes by. Swelling is there. Redness is there. And they still told her it's normal. The PIC team is taking their time. They can't get to you. We need these antibiotics in you right now. So we need to keep this IV medication going. It was extravasated the whole time. Infusions should not be painful. What about potassium? How many times have I told my patients, yeah, it's normal, it's electrolyte, it's good for you. It's in Gatorade, it's not gonna hurt you. There are no nerve endings in the tunica intima of the veins. They shouldn't be feeling it. I snag my needle every once in a while under ultrasound. They don't feel it. They should not be feeling pain. This patient, let's get a little philosophical here. For the end of time, until eternity, from when this picture was taken, you will never see another picture of this man's arm. They had to amputate it. This is the last picture that exists of this person's arm. This is a bicarb infiltration that was ignored throughout the time of his treatment, so they had to amputate. This is what it costs for our patients. This is what it costs for our patients. This is what it costs for our patients. Now, am I saying that if you use ultrasound, you will never extravasate? Of course not. If you use ultrasound, will you never miss? Of course not. But the likelihood is very low. Why? Because we can see where we're going. Ultrasound should be the standard, not the exception. For our sake of our patients, we need to raise the bar, and it has to start in the ER. Where's the first place they usually get their IVs? From us. Yeah. Where's the first time they get poked? Multiple times. From us. So let's try to raise the bar for the rest of the hospital. What are the downsides of standardizing ultrasound? What are the downsides of not standardizing? Anybody know? It's too expensive. You heard that before, right? 30,000. I can't buy 30,000 units, 3 at a time, replace it. How much does it cost to replace that probe that you broke? 10? 10,000? 7,000? My probe is 2,700. We can buy 2, and it's more durable. I don't want to lose my blind stick skills. I'm okay losing my blind stick skills. I don't want to do that. I want to see where I'm going. I want to see where that needle's going. It is the most commonly invasive procedure we do for our patients every single day. It should be the standard, not the exception. We need to raise the bar.
Hurry up. Hurry up. Hurry up. Hurry up, hurry up, hurry up, 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 hurry up, hurry up, hurry up, 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 hurry up, hurry up, hurry up, 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 hurry up, hurry up, 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 hurry up, 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 hurry up, hurry up. No, you idiot, I'm asking you to hurry up.
I'm dancing as fast as I can.
So why am I in such a rush? 35 to 50% failure rate before end of treatment. Before they're done with their IVs, 50% of our patients needs to be re-poked, re-stuck, because they're not working so well. We need to figure this out. Imagine this. Ladies and gentlemen, this is your pilot speaking. I will be landing our plane today. I'm not a punk. I don't like to use machines. We will be doing everything manually. I've landed successfully. 35 of it didn't go so well, but I am the best at what I do. Hope you enjoy the rest of the flight. I don't want to get in that plane with this kind of failure rate. Does that make sense? If I went to a hospital and they told me, hey, you're going to get poked multiple times, by the way. It's like, oh, I don't want to go. Non-compliance shoots up. What about this one? This is an interesting one done in ER by Loon and Associates. 400% chance you're going to get poked multiple times if you're a known diva. We knew this. As ER nurses, it's intuitive. We know if you come in as a diva, we're going to have problems. But we're still telling the patients that we need to poke you multiple times. Hey, I know you come to this hospital a lot. You're a regular. We love you. You don't ask for turkey sandwiches all the time. You don't kick us in the face. You don't cuss us out. But we have to poke you 6 times. It's policy. We're not even going to call for the ultrasound. But we're going to poke you 6 times. You're going to have to deal with it because it's policy. Just to let you know, it's going to happen. There's a 400% chance this is going to happen. What's the compliance going to be of patients wanting help after that? It's a difficult thing to ask them to keep coming to. This is more for the managers and leadership. 9 PIVCs wasted in the US per patient. How much is an IV? Huh? $5. 5 times, 9 times every patient is how much we're losing. So here are the downsides of not adopting ultrasound. So we have redness, blistering, signs of infiltration. What would you say? I'm so terrible at identifying edema. Would you say this? Complications because we didn't know where it was and we couldn't confirm that it was in the right or wrong place. But with ultrasound, we can. I'm going to show you some videos of what you guys are able to do with the ultrasound. Should be the standard, and I think the ER is at a place where we can elevate that standard. Why? Because you're in this room right now. You could have been at home in your underwear, eating bonbons on your bed, doing CEUs from home. But you're here today. Some of you had to, pull tooth and nail to get your employer to pay for this one, right? But you're here today because you care. So I expect that you guys are able to meet my expectations because you're here today. And that's why I'm here too, spending my time with you guys. For the sake of our patients, of course. But why? Why do we care? Why is this such a big deal? I know, I don't do well with numbers. I'm just going to save you guys some time. 800-bed hospital, 867-bed hospital. Least year the PIV5 rights implemented saved $3 million on just wasted PIVs and equipment and time. It's a significant reduction in waste. You want to convince your C-suite, hey, we have a budget, we'll make a budget. It takes too long to grab the ultrasound, then assess, then more equipment. You are correct. Initially, it will take more time for that first stick, of course. However, how much time are you going to spend when you missed? How much more time are you going to spend going to grab more equipment? How long does it take you to continue to miss? You're there for a lot longer than 20 minutes, I guarantee you that. But what if we can get it in one poke? We don't have to wait and waste all those hours. So it is a time-saving measure as well. Let's raise the bar. Ultrasound technology, okay? So,
the original machine had a base plate of prefamulated amulite, surmounted by a malleable logarithmic casing.
What?
In such a way that the 2 spurving bearings were in a direct line with a panometric fan.
okay.
The lineup consisted simply of 6 hydrocoptic Marsal vanes, so fitted to the ambifacient lunar wane shaft.
Okay. Look, the technology is very, very abstract. It's a beam of energy, but I'll try to save you and spare you the complications. This is it. That energy needs to hit that probe back, and this is the most common thing we miss in ultrasound. And if you guys stick around after my talk or after everyone's done, I'll be out there at the exhibit hall going over everything with you guys as well over there. This is what you can see.
I'm going to show you what happens when you flush too hard. You see that valve? Yeah, because I've never seen a valve that prominent before. Wow. So there's still pretty good blood flow, enough to keep the valves
You got your
open.
valves right here.
Right.
Catheter here. Now, look what happens when you flush too hard. And what does too hard mean? What I did every day.
You're not going to see this for a very long time. Enjoy it.
Very prominent double-layered valve. And the little bulbular structure here. I can see the anatomy.
The base of the valve and the leak.
Otherwise. You guys see that flow?
Here's what happens when you slam it. You see that? Did you see that vein
What's going
close?
on here?
You see that?
How many of you have flushed really hard hoping you'll open up and
See how the vein got smaller now?
I used to
That's
think
what you're
that.
doing.
I used to think if I flush harder, then it'll push out all the clots. It's actually collapsing your veins. It's called the
spasming the
Venturi
vein.
effect. Blew my mind. I had
Irritating
no
if you're
idea.
flushing it too hard.
Until I saw it with ultrasound and it changed my practice. Here's another one.
I think that's a little clot at the tail end.
What's that right
When I
there?
try to pull, you can see it getting sucked in.
Anybody heard of fibrin sheath?
So that's definitely a fibrin tail.
This is a fibrin tail. extruding from the external of the catheter. This is a 3-day dwell of a 22 gauge.
Longer.
Look what happens when I try to aspirate. It collapses on itself. Now, is this safe to use? Sure, right, it is.
There's a fibrin sheet that developed.
Just because it doesn't draw blood doesn't mean we can't use it.
That's an intraluminal
But I've
thrombus.
proven it with ultrasound.
Look at how when I try to suck in.
So it crumples up that fibrin sheath and we're not able to draw blood. So this is one of the possibilities of something that's happening. But how many policies were created telling you you can't use that IV if you can't draw blood? It's not necessarily true.
All right, so here's our base.
Is that one going to play? Yes, it's a longitudinal view, yes. I can see the whole pathway of the vein in the cath. This is important because this is going to apply more to you guys as well. There it is. I don't know, the audio's not working. What is that? Anybody know? What was that? Sclerosis? Good guess. No. Oh, is there? You don't want to take the blame. I love it. I love it. It's a thrombi forming. The patient felt a little resistive. I felt a little resistive too, but it flushed well. No swelling. No swelling. Am I concerned about extravasation? Yes. So I assessed it with long view, and it was still patent enough to flow for his last dose. I didn't have to poke him again for his last day of antibiotics. Can I draw blood from this? No. But is it usable? Yes.
All right, so here's our baseline image of the catheter
I did not
and
believe
vein.
this until I saw it. Spasms,
Now
whatever.
I'm gonna
It's saline. Who cares?
Flush hard.
Saline is the most neutral thing in the
Let's
world.
see what it
right?
looks like from here at baseline.
So here is a hard flush,
Okay, this is me slamming the flush.
and then it's going to show you the
I'm
difference
going to
between
measure
the
it
two
to see if there's
flushes.
any.
If I did not
spasm.
see this under ultrasound, my practice would have continued the
That's from
same.
slamming it like I used to in the ER. There we go. We'll compare this to what it
Do you
was
see
before.
the constriction of the veins? We can see that. My eyes have been open to so many practice minutiae that has now extended the life of the catheter for the sake of the patient. Now they can keep using these for a lot longer. So these are little things that we didn't know. Now, in conclusion, okay, why am I talking about all of this? Because for the sake of our patients, we need to standardize, I think we need to standardize the ultrasound insertion and make it standard and not the exception. Don't get it until after 7 pokes. If they're a diva, just grab it first thing. We can't afford any more ultrasounds. They're $2,700. They're significantly cheaper. Let's get a few for the unit. It's cheaper than replacing that entire probe when it breaks frequently. So these are some things that you guys can use to help raise the bar. The ER is the first place to poke. A lot of times, if there's no vascular access teams, how many go up to the floors to help assist with IV insertions? Yes, because you guys, we are the go-to people for IVs. So it's up to us, I think, to raise the bar, standard of care, and standardize ultrasound insertions, because our patients are suffering from what we're doing. They had to before, because we didn't have the technology, we didn't have the skills, but now we do. And I know a lot of hospitals are adopting more ultrasound over time, and I'm very excited for that. So for the sake of our patients, we need to raise the bar.